Thank you. Hi, I'm honored to be with you in this nice event, and I would like to thank the organized this congress. So I'm Safa Baris. I'm professor from Marmara University School of Medicine. For the primary immune deficiencies. So, as mentioned before, the primary immune deficiency is exponentially growth with the advance in the next generation sequencing, and there is almost 430 genetic defects described, and most of them are autosomal recessive disorders. And it's day by day, it's still to increase. So there is a 10 subtypes of the primary immunodeficiencies described, and most of them showing increased rate of infections, especially respiratory, but also there is patients that showing immune dysregulation characterized by autoimmunity and chronic autoinflammatory disorder, and also malignancies. So those are called disease of immune dysregulation. So I'm going to talk about the immune dysregulatory disorders because it's the number is growing. Almost half of the primary immune deficiencies showing immune dysregulations. As I said, it's characterized by autoimmunity, hyperinflammation, and also lymphoproliferation and malignancies. Interesting, we are seeing less prominent of recurrent of those patients. That make a dilemma during the diagnosis and follow-up those patients. So this is the slide showing the mechanisms, possible mechanisms for immune regulation in primary immune deficiencies. So there is multiple pathways that's important for the making tolerance for our immune system. That's keeping our self-proteins from the from fighting with the immune system. So there is some. If we have a problem with those steps, probably we will get immune dysregulation. So, and also autoimmunity. Like there is a model describing the T and B cell development and tolerance. If we have problem with those, like severe combined immune deficiency or Omen syndrome or combined immune deficiencies. Also, if we have a T cells signaling problem that's causing combined immune deficiency and lead to autoimmunity, and regulatory T cells is very important for the immune system. If we have a problem with regular T cells like IPEX-like disorders, we have autoimmunities, and also the other pathways like interferon signaling pathways, and also a problem with the clearance like complement system. If we have a problem with those system, we will get autoinflammatory and lupus or lupus-like disorders. And the other pathways like apoptosis, hyperinflammation, we usually getting, if we have problem with those pathways, getting ALPS and HLH disorders, and some new described inflammatory bowel disorder and rheumatologic disorder characterized by a gene defect and causing primary immune deficiencies. So immune dysregulatory disorder, like characterized by now three classification, like ALPS-like or IPEX-like or CVID-like disorders, and all of them showing autoimmunities, like the mainly with ALPS like disorder, there is hematological autoimmunities. whereas in IPEX-like disorder, there is much from the hematological to almost all the systems can affect it, like causing enteropathies, type 1 diabetes, dermatitis, thyroiditis, arthritis, and vasculitis. CVIDs, like disorders, they showing autoimmunity, but they also show recurrent infection and hypogammaglobulinemia. So we can differentiate clinically those patients with the history of infections. So with the description of many genes and pathways, the therapy also moved from the classical therapies like immunoglobulins replacement or antibody prophylaxis to more special therapies, those calling the concept of precision medicine or targeted therapy. So it's more effective than when compared to classical therapies, because it's directly to the immune pathways, and also effective to control disease control, showing less side effects. And we use those drugs to control the unbalanced immune dysregulation and autoinflammation. So there is many drugs like implemented for the primary immune deficiencies, and also especially for the immune regulatory disorders. Most of them like listed here. And there is mTOR treatment for especially for the ALPS and LRBA CTLA4 deficiencies. And also we are using abatacept therapy to blocking the co-stimulation, especially in LRBA and CTLA4 deficiencies. And the rest, like JAK inhibitors, and also PI3 kinase pathway inhibitors, which show very promising responses in patients. So I'm going to talk about the LRBA deficiency in more specific, and also our new studies published in journal Allergic Clinical Immunology in Practice. So LRBA deficiency is autosomal recessive disorder characterized by recurrent infection and lymphoproliferation, and also there is a huge amount of the autoimmunity in like brain or in lung tissue. So there is diabetes, colitis, and arthritis in those patients. So this is when we looked at the pathomechanism of the disorder. LRBA, it's intracellular protein that's keeping CTLA4 from the lysosomal degradation, and by this way CTLA4 go to the surface and acting as a inhibitor molecule that's capturing CD80, CD86, and inhibit the cell proliferation, and also stop the immune system. So if you have the problem with the LRBA, so the CTLA4 degraded more and cannot go to the surface of the cells, and this is causing the lead to the multiple autoimmunity, and also to expose to the patient to the infections. So we are here. We are using the CTLA4 Ig fusion protein. This is abatacept. It's contain external domain of CTLA4 and also IgG1 Fc domain that's causing fusion protein. And we are using these drugs for the more than 10 years for the rheumatological disorder. But after discovery of LRBA deficiency and the link between the LRBA and CTLA4 molecules, some patients before diagnosis who suffer from the multiple autoimmunity showed that have favorable responses with the abatacept, and they found to have LRBA deficiency. So but we until date we don't know the exact dose for those patients, and also we don't know the long-term effect of the abatacept in LRBA deficiency. So we decide to conduct a study that showing a long-term effect of abatacept. So we check the clinical responses, long-term efficacy, and we try to look to the doses and intervals, side effects, and check the immunological changing during the therapy, and try to find biomarkers that showing the disease activity. So we recruit 22 patients from different centers from in Turkey, and follow those patients for the 1 year prospectively, and every 3 months we analyze the immunological phenotype. Also, we follow up clinically the patients with the clinical manifestation, and for the targeted therapy, abatacept, the efficacy and safety by controlling the disease severity and response, categorize the responses to drug as a complete remission or partial or non-responsive. So this is the demographics of the patient. There are 16% of male patient, and the follow-up was 3 years, and as you see, the delay time of diagnosis was almost 10 years. And before the diagnosis with LRBA, initial diagnosis for those patients was were CVID or ALPS, and less is IPEX-like disorder, or one patient was asymptomatic, which diagnosed after genetic screening. So at the end of our study, there are 91 patients alive, and 2 patients was died. And most clinical phenotype was recurrent infection and lymphoproliferation, immune dysregulation with many autoimmunity, like ITP, hemolytic anemia, and arthritis, type 1 diabetes. And 16 patients also show failure to thrive. And this is the mutation of our patient. Most of them have stop gain or friendship mutation, and all mutations, as you see, disrupt the gene, and there is no correlation between the genes and phenotype of the patients. And we try to we compare the different doses, because since every center use different dose for the abatacept, and we check which dose and interval is more efficient to control the immune dysregulatory, chronic diarrhea, and lymphoproliferation of patients. And this is the median duration of the therapy. As you see, it's 1 year, but change from the 5 months to 3 years. And the abatacept showed almost control to the in Can you hear me? Sorry.
Yes, yes.
Sorry. Sorry. The abatacept showing most clinical response for the lymphoproliferation and chronic diarrhea, which almost 80% of the patients respond to this therapy. However, the immune dysregulation showed less response, like 40% show of the patients show complete remission. So when we look to the hematological immune dysregulation, most of the autoimmune hemolytic anemia and ITPs patients showed complete remission. However, the other immune dysregulatory like alopecia, arthritis, diabetes, and neurological disorders and interstitial lung disorder showing a partial response to abatacept. And this is the interval of the drugs. When we use the drug every week or every 2 weeks, they show better and shorter time of the to control this disease symptoms when you compare to 4 weeks therapy. And also every 1 week, it's more efficient than the every 2 weeks therapy. And we also test if there is any biomarker that's showing the disease activity. And this is the collaboration with the Harvard Medical School Professor Dr. Talal Chetila. We showed that the LRBA deficient patients showed high follicular T cells. This is due to inefficient suppression by CTLA4. And they show high circulating follicular helper T cells that's also characterized by activation, like showing ICOS and PD-1 activation markers. We looked, we test the CTLA4 in more patients, like all of the patients in our cohort showed very nice response by decreasing the circulating follicular T cells. And as you see here, it's in the baseline, they have high follicular T cells compared to control, but after therapy, it's statistically decreased. Also, it's the activation marker, the PD-1, it's also high in the patient, but decreased after the therapy. And also we look for the soluble CD25. It's also showing the inflammation in those patients, and it's high in the baseline, but after therapy it's statistically decreased. And we have, interestingly, 2 patients that's not respond to the abatacept therapy, and also they showed high circulating follicular T cells during the therapy. Also, it's which decrease only after transplantation in 1 patient. So we, when we look to those 2 patients in more closer, so those 2 patients showing more disease activity and longer disease course when you compare to the patients who respond to abatacept and show decreases in circulating follicular T cells. And the persistent patient also show very low lymphocyte and very CD3 T cells, B cells, and NK cells, lymphopenia, and also they show dysregulatory phenotype characterized by high memory CD4 T cells. And we showed also a restoration in naive T cells in most patients, and basically naive T cells, it's decreased with the abatacept therapy. And there is no change in TB and NK subsets during the therapy. So here I would like to conclude that the targeted therapy abatacept was efficient to control the disease manifestation in LRBA deficiency, especially for chronic diarrhea and lymphoproliferation. And the responses was more favorable with weekly or biweekly therapy. There is no serious side effects. And also we showed that the soluble CD25 and circulating follicular T cells, it's a reliable biomarker to control the disease activity, and also to uncover patients with resistance to therapy. And I would like to also mention that targeted therapy can be more efficient with less side effect in patients with specific gene defect, and also initiation of those therapies in early stage can provide more disease control and also better immune restoration. That's allow more successful bone marrow transplantation in a patient who requires transplantation. At the end, I would like to thank to our colleagues from my department and also to others people's colleagues from the different centers and universities from that contribute to our study. Thanks.